Hello, greetings. My name is Achille Manirakiza. I'm a clinical oncologist based in Kigali, Rwanda. It is my pleasure today to join you at the Best of ASCO meeting on the talk related to head and neck cancers. My talk today will be based on a trial that was made for patients with head and neck, high-risk head and neck cancers, post-operative in the post-operative setting. So I'll pull up my slides here. So essentially the study was a phase 2/3 trial that essentially was they wanted to see for post-operative chemoradiation therapy, they wanted to compare the 3-weekly cisplatin versus weekly cisplatin for high-risk patients with squamous cell carcinoma head and neck. So this was a Japanese study made about a few years ago, but it was presented in this year's meeting at ASCO. But what we knew before this meeting, before this presentation, was in the Red Journal in 1996. There was a study that was published that looked at it compared addition of cisplatin to radiation versus radiation alone in head and neck patients. This study was made around the time when cisplatin was found to be a good addition to squamous cell carcinoma cancers, and this was a discovery also done in cervix and so on. So this was found, weekly cisplatin plus radiation was found to be better than radiation in head and neck carcinoma. But what came out a few years later was that, you know, two studies were published differently, but then they had also a joint analysis, and they found that 3-weekly cisplatin plus radiation was actually better, and it was made to be the standard of care for many years. But the problem with that was that there was a low compliance and also a high rate of adverse events. The features that were made to establish the patients needing this were patients with microscopic positive or closed margins, also patients with extranodal extension. In 2018, there was an attempt to compare weekly cisplatin versus 3-weekly cisplatin at Tata Memorial, and it was a single institution study. They only found poor outcomes for the weekly cisplatin plus radiation compared to 3-weekly cisplatin plus radiation, with a 2-year overall survival much lower in the weekly cisplatin regimen. So this study wanted to make a difference a bit. They gathered about 28 institutions in Japan, and essentially had patients with in the post-operative setting with, you know, a high stage, stage 3 and 4, you know, a pathological stage, having microscopic positive or closed margins, and also extranodal extension, as I've said. And also they tried to expand the locations of the head and neck cancers. The study in 2018 in India was based mainly on oral cavity carcinoma. So this one essentially looked at oral cavity and below. So they randomized patients one by one in the arm A of 3-weekly cisplatin. Cisplatin was about 100 milligram per meter square. If you divide it by 3, the 3-weekly regimen, it becomes a bit lower than what they gave in the weekly cisplatin regimen. But the radiation therapy was 66 by 33. Now, in the techniques that they gave, the techniques of radiation, one was they actually gave either 3D conformal radiation or IMRT. There was no distinction between those. Now, the reason why they did phase 2/3 was to actually see if patients are able to complete the chemo regimen, to see if patients can be given at least 2 or more cycles of cisplatin in the arm A of 3-weekly cisplatin, or 5 or more cycles of cisplatin in the weekly cisplatin arm. In the phase 3, they wanted to now see the overall survival as the endpoint. They had several other endpoints on the side as secondary endpoints, essentially to see the recurrence, the relapse, and also the adverse events. They also wanted to prove that weekly cisplatin is non-inferior to 3-weekly cisplatin. So the eligibility criteria, the only added components from what I've said was the timing of surgery, which had to be about 56 days from curative surgery. They didn't go beyond 56 days. That was mandatory. I know this is quite a challenge in many of our institutions, but it is now mandatory, and it has to be taken care of before you give radiation to these patients. The age and also the performance status. Also no story of chemotherapy, radiation, or hormone therapy. In phase 3, the target sample size was about 66 patients, and in phase 3 they got up to 260 patients. We're going to focus on the phase 3 part. They got about the targeted sample size, but a few patients were excluded from the study for various reasons. And in addition, a total of 129 plus 122 in each arm received the treatment and completed the treatment. The factors that were taken care of, taken in consideration are here. I just want you to focus on the interval from surgery to radiation initiation, which didn't go beyond the days we've spoken about, which is approximately 8 weeks between surgery and radiation. That's also the time we have to consider when we plan. So the planning of radiation has to happen around that time as well. Radiation timing, the duration was about 49. That is when you also consider the days of the days off, the two days off per week. The total dose of radiation was about 66 in every arm. Now, in pink, you have arm B. In blue, you have arm A. So weekly cisplatin, 3-weekly cisplatin. In overall survival and the interim analysis, that was found at 2 years, because the criteria for interim analysis was actually met at about 2.5 years. So we had an advantage of the weekly cisplatin compared to the 3-weekly cisplatin age of overall survival. There was also an advantage of the weekly cisplatin in terms of relapse-free survival. And also in terms of local relapse-free survival, there was an advantage of the weekly cisplatin. In the acute hematological toxicity, the major finding was that arm B had less toxicity, and which is quite interesting, because as you can imagine, the 40 milligram per meter square per week is much higher if you subdivide the 100 milligram per meter square every 3 weeks, if you subdivide it per week, because that will be about 33 milligram per meter square. So these patients were receiving a weekly cisplatin dose of 40 milligram per meter square, had less hematological malignancies than the patient receiving 3-weekly cisplatin. This was also the case for non-hematological toxicities. I spoke of malignancies, it's actually adverse events, I'm sorry. Also in non-hematological toxicities or adverse events were much lower in the weekly cisplatin regimen versus the 3-weekly cisplatin regimen. In summary, so this study met its primary endpoint of non-inferiority in overall survival at about 2.5 years. And you know, we can easily and comfortably say that weekly cisplatin in head and neck is non-inferior, is equal, or has the same efficacy in terms of and in terms of overall survival, also in terms of overall survival, it has about the same overall survival as the 3-weekly cisplatin regimen. It has a better relapse-free survival. It has better local relapse-free survival. and also a favorable safety profile in terms of adverse events. In conclusion, so this study essentially has shown that the non-inferiority profile also, that it can also propose and suggest the weekly cisplatin plus radiation as the new standard of treatment in head and neck squamous cell carcinoma patients. The final analysis is slotted in about 2 years from now, and we're waiting to see everything it brings about. This is pretty much the end of my presentation. I thank you so much for being attentive and listening to this presentation.